Now, Executive Suites with WPRI.com reporter Ted Nesi.
Welcome to Executive Suite. I'm Ted Nesi, and we are talking this week about one of our favorite topics, the business of healthcare in Rhode Island, a major sector and one that's going through a lot of changes right now. And we have today with us one of the top executives from that world, Diana Franchitto. She is the president and CEO of Home Care and Hospice of New England, but you might know her organization better as Home Care and Hospice of Rhode Island, and then of course you merged a few years back with the Visiting Nurses Group, right? So a bunch of different organizations, all pretty well known around here. We're going to talk some more changes happening there, but Diana, thanks for coming.
You're welcome. Glad to be here.
So let's start off with the easy question I ask most people. What do you do at Home Care and Hospice of New England?
Right. So I am fully responsible for making sure that we have excellent quality of care and a wonderful trained staff to provide that care. And secondly, I need to make sure that we're a financially strong, well-managed organization. For Home and Hospice Care of Rhode Island, what most residents in the community know us for, as well as Visiting Nurse Home Care, our home care agency.
So get us into the weeds a little of what your people are doing in those two organizations.
Sure. So from a Home and Hospice Care of Rhode Island perspective, we provide, as the largest provider of hospice and palliative care in the state, care to folks who are seriously ill and in their final months of life. And so with that, we provide all sorts of medical care, spiritual care, psychosocial care through our social workers, and we even have over 350 volunteers to provide companionship and other care to the residents in Rhode Island.
So that's the hospice care side, right? So people are going to think it must be extraordinarily depressing because you're talking, people are uncomfortable often with death. What do you say when people say that?
So I think it's actually not, believe it or not, and there's a certain amount of joy in the work we do, and that's largely because we are given this opportunity to provide care when time matters most. So I think of it as babies and end-of-life care. Babies, you have this clean slate, a wonderful opportunity to make sure that a child is well-positioned, healthy, and good when they come into this world. By the same token, at the end of life, no matter what has been in between, whether it's a wonderful, charmed life or a life filled with tragedy and challenges, we have this opportunity to provide dignity, comfort, great care so that the last months of life are really a memorable time, not only for the patient, but the families they leave behind.
And also you put that very eloquently, and I assume also as comfortable a time as it can be if someone is sick.
Absolutely. To really focus on how can we make sure that our patients are comfortable. And that is a science. Hospice and palliative care is absolutely a medical specialty. 10 years ago it wasn't. It is now requires board certification if you're a physician, and there are all sorts of certifications if you're a social worker, nurse, hospice aide, etc.
So that's on the home, the hospice side, and then on the visiting nurses side.
Sure. Visiting nurse is all about getting better. It is all about helping people to restore themselves to regain a life of independence. So whether they've had a joint or a hip or a knee replaced, or have had some surgery and have to have some visiting nurse at home to manage the surgical incision, whatever it is to get them back so they can have a full and active life again. However, we also know that as a visiting nurse organization, we care for some very sick people, very, very seriously ill people. And with that, as they continue to decline, we will be able to transition them to hospice through our palliative home care program, that when the time is appropriate and they're ready for hospice, they can stay within the same family of organizations.
And one thing I learned doing my research for our interview today, hospice and palliative care are not the same. They are two different things. I feel like they might get conflated sometimes. So can you tell us, what's the difference? What do you mean? What's hospice really mean, and what's palliative really mean?
Sure. So you're absolutely right. Hospice and palliative care are always said as the hand in glove. And so hospice, and we'll compare it to palliative care, hospice generally means that you are really trying to seek comfort in your final months of life. And so it is, I'm done with seeking the cure. I've been through the many rounds of chemo, radiation, or whatever it is, and unfortunately they haven't proved beneficial. And so now I'm going to focus my final months of life having comfort, being with my family. And so with that, you get the benefit of this, what I call the football team of hospice. So you have the nurse, you have the physician, the social worker, the grief counselor, the chaplain, the whole team focused on providing you with extraordinary care in those final months of life. Compare and contrast that with palliative care, where it is very focused on managing pain and symptoms when you are seriously ill. You may not be in your final months of life. You may have a very advanced illness, cardiac disease, lung disease, and you require someone to manage your pain and symptoms because your disease is continuing to get worse, but you may not be ready for hospice yet. And so that, in a sense, is almost a precursor to hospice.
It sounds like a zone in the middle maybe there, yeah.
And you also may be seeking a curative treatment while you're in palliative care. And so generally, it's a physician or a nurse practitioner that's providing palliative care, but you don't get the benefit of what I call the football team of hospice.
And now, I remember when my mother was dying many years ago, and I believe that to initiate hospice care, we had to accept that we were stopping treatment. It was the moment there was nothing they could do, and we wanted her to be comfortable. Is that always the requirement for hospice?
Right. It is a requirement of Medicare and all of the other insurers, and generally they need a physician to say that the patient's prognosis, it would not surprise them if the patient had approximately 6 months left to live. And so that is the requirement part of the work that we do. So
part of why I have you on today is because you've recently made some big news about the future of your organization in October. Tell us about it. What's happening?
Sure. So we will now be able to expand into Massachusetts through an affiliation with HopeHealth. HopeHealth is a very similar organization to Home and Hospice Care of Rhode Island, one of those legacy organizations, community-based, founded by volunteers, where they have just this extraordinary mission. And so there was an opportunity with the retirement of their CEOs for our boards to talk strategically about would this be beneficial for our community residents as well as the organization to not let a boundary get in the way and join forces. And so that's really the exciting news that we shared about 2 weeks ago.
So what's the timeline for closing on the deal and actually merging the two organizations into one?
Sure. So on or around January 1st, we will have a closing, much similar to your house. And then I have already started there as the CEO. So I'm splitting my time between Providence and the Cape, where their headquarters are.
Wish it was summertime probably as you do that,
the
right?
Cape in January,
yeah,
right?
exactly. Now, will cash change hands? What kind of transaction is it?
No, right now it will legally allow us to work together and share resources. And by that I mean at some point transition to a common electronic medical record platform where we can begin having shared management resources so that you don't need two CEOs and you have one CEO, and the infrastructure that you're able to spread across two organizations that serve quite a number of patients will be much more judicious use of resources by spreading the costs across that.
And we have to go to a break, but before we do, have you decided the name of the new parent company for the whole organization?
We are going to adopt HopeHealth as the name of the parent organization.
Now, will we see that on the side of your famous building and people know in Providence?
Yeah? Absolutely. All the signage, and we're planning for a mid-January rebranding.
Okay, all right. We're going to talk much more with Diana when we come back about the mission of Home Care and Hospice of New England and HopeHealth as they become that. So stick with us on Executive Suite. Welcome back to Executive Suite. I'm Ted Nisi, and we're talking today about the healthcare sector with Diana Franchitto. She is the president and CEO currently of Home Care and Hospice of New England, which includes Home and Hospice Care of Rhode Island, as well as the visiting nurses, and soon will include and be rebranded with HopeHealth out of Cape Cod. And we're talking about that transaction and Diana's excitement about their expansion there. Now, there could be employees of either organization watching today, HopeHealth or your one. Right. They're going to wonder, they always wonder the merger, layoffs. What's it look like? What's the employment front?
No layoffs whatsoever. This is really an affiliation all about expansion. And so with that, our employees that are with Home and Hospice Care of Rhode Island will continue seeing their patients and doing the wonderful work that they do. And similarly with HopeHealth in Massachusetts, they will continue to do. So this is really more of a strategic initiative focused on expansion.
Now, you became CEO, I think, in around 07. Do I remember that right? 07. And so this is actually the second significant expansion since you were in the top job, because the visiting nurses combined with Home and Hospice Care in 11 or 12. Yep. And now you're doing HopeHealth. Why have you clearly looked out there in the world in 07, 08 and said, we need to be bigger. Why were you thinking that, and why has that been part of your goals?
Sure. So often people confuse home care with hospice, and they are two very different lines of healthcare service. However, the similarities are that we provide care in the same location, in the homes. And often people are so sick on home care that they don't often transition to hospice in a timely way. And one of the issues that the state struggles with is we are one of the shortest in terms of hospice length of stay in this country. And so that was one of the strategies that we employed to help people move to hospice in a more timely manner rather than being brink of death care, because that's not what hospice is.
Well, let's talk more about that. That's interesting. Someone might watch and say, well, good, like we don't want people on hospice, we want them out living their lives and well. Clearly not what you see. When you see that statistic, what does it tell you?
It tells us that people are in ICUs, they're having hospitalizations, they are suffering, they may be in pain, getting the wrong level of care for too long before they enroll in hospice. And so what hospice will provide is an enormous team effort caring for patients, as well as the financial responsibilities for patients are gone because the hospice benefit, particularly Medicare, and other insurers have it, is really aimed at taking away the financial burdens of care at the end of life. When Medicare said that we want to start paying for end-of-life care back in the early 80s, when does the government ever say they want to pay for health care, right? They knew that hospice was so important that every American deserved to have time at the end of their life where they didn't have the financial pressure and could count on good quality care.
And that was kind of the whole idea, because hospice is, as I understand it, it was in the 70s. So this year's was only the second one, I think, to start up. And it was sort of to get away from the idea that until the day you die, you should be in hospitals and hooked up to machines and that kind of thing.
Right. Really, the origins of hospice were to allow cancer patients to die at home. But we all know that people die from a variety of illnesses, from heart disease, lung disease, cancer, dementia, and many of the other neurological diseases. So now hospice is, no matter what is your terminal illness, that hospice can come in and care for patients in the setting of their choice, whether it's a nursing home where they live or have lived, or in their own private home.
I'm curious, you're intimately familiar with how families handle these end-of-life decisions. Yeah. We had that big furor when the healthcare law was being debated about death panels, which was the word used oftentimes. What did you make of that? Just as, not in a political way, but more as someone who knows about this stuff, and what were you thinking at that time?
Well, it was actually very sad, because the healthcare community has been struggling with this for a long time. How do physicians have really meaningful conversations with their patients? And we're not talking about physicians who just got to know a patient. We're talking about primary care physicians that have had decades of a relationship with a patient and their families. And to be able to have a meaningful conversation about the progression of their disease, and what are your desires and what are your wishes? So unfortunately, that took, a turn that none of us wanted to see. But I think as a society, we've certainly come a long way. And when you think of the upcoming holiday season, the best gift that we can give each other is sharing our wishes about what you want, what I want, what our parents want for when they become seriously ill. That is the biggest gift that we can give our loved ones.
And what is your advice? What challenges do you see families run into if they haven't had these conversations? What's your advice coming out of that? What practical steps should they take, do you think?
Right. Well, I think there's fear. Nobody really wants to talk about it. It's not the most uplifting discussion. But if you truly care and love for a family member, it's important to have that discussion. Well, at the end of the day, everybody thinks about their own mortality. And, you often hear, but I don't ever want to be, hooked up to a machine is often what you hear. And I think, getting direction from loved ones about what they want. And it doesn't have to be an awfully long, painful conversation. It's just, if something should happen to me, or if this disease continues to continue my decline, what do I want? And so it's letting your loved ones know what's really important to you, what matters.
All right, we're going to take another break. When we come back, we're going to talk more with Home Care and Hospice of New England CEO Diana Franchitto about what's going on with their organization. Stick with us on Executive Suite. Welcome back to Executive Suite. I'm Ted Nisi, and we're talking today with Diana Franchitto. She is the president and CEO since 2007, almost a decade now, of Home Care and Hospice of New England, and they are creating a partnership, merger, affiliation, whichever words you're going to use, with HopeHealth of Cape Cod, and they're going to be changing to that name within a few months and getting that going. One interesting, among the interesting things you do at Home Care is you have an academic affiliation with the medical school at Brown, which is interesting, and as I understand it, kind of rare around the country. Tell Tell us about that.
Sure. Following up on what we were talking about, having conversations and understanding what our patients want as their end-of-life wishes, what better opportunity than to have the privilege of training the next generation of physicians in hospice and palliative medicine? And so we are the major teaching affiliate for the Warren Alpert Medical School of Brown University, where they have entrusted the training of hospice and palliative care into our organization, Home and Hospice Care of Rhode Island.
How did that come about? That's interesting.
We have had deep roots in the medical community, starting with our founder, Dr. Stanley Aronson, who was the founding dean of the medical school. And he knew back in the 70s that this was so important, and his mission was to change the way people were dying in Rhode Island, because he had an opportunity to see some of the suffering and the difficulties patients and families encountered. And so his mission of creating this organization, when it was funded by bake sales and car washes, is now the largest in the state, one of the oldest in the country, and has a real academic slant to it as well.
Now, as we look at the HopeHealth merger happening, it's interesting because we are also seeing right now, just in the news, is Care New England with their merger discussions with South Coast Health of New Bedford. Very similar footprints there. You have a big Rhode Island institution looking at a big southeastern Massachusetts.
Right.
Do you think, is that a coincidence, or do you think there are reasons we're seeing that kind of cross-border looking at each other among the orgs?
Well, I think what you're seeing is that a recognition that healthcare is going to be regionalized. And so with that, when we looked at our market, believe it or not, Rhode Island is heavily penetrated and there's a high hospice utilization in Rhode Island. And as we looked at the market, there is kind of this triangle from Boston to Hyannis and to Providence, and HopeHealth in Massachusetts covers from Cape Cod all the way up to Boston. And so it made perfect sense from the regionalization of care, particularly in the hospice and palliative medicine sector.
Now, once you are one organization, how big will you be? Employees, patients, revenue, how sizable will it be?
So we'll have over 650 employees. We will have 400 volunteers. We will have $75 million organization. That will be our budget, and so we will be a sizable organization where we will be caring for over 2,000 patients every day.
Looking ahead, we hear a lot about the demographic changes in Rhode Island and nationally as the baby boomers get older, and also that people are always talking about the statistic now that Rhode Island has the highest 85 and older, not 65, but 85 and older population in the country. Is that something on the minds of the planners at your organization about how to deal with that?
Yes. Rhode Island is number 7 in the 65 plus population. It's number 4 in the 75 plus population, and number 1 in the 85 plus population. What that tells us is that from 65 on, more and more people are going to be needing access to really good home care and really good hospice care. And so just purely from the demographic and the aging of the baby boomer population, and in this country there are 10,000 baby boomers turning 65 every day for the next 20 to 30 years. So that means really strong hospice programs are going to need to be in place to serve the community. Another
big change we've seen in recent years, the rollout, of course, of the Affordable Care Act in 2010. You've mentioned repeatedly Medicare and how important that is to how you do what you do. Have you been impacted by all the health reform changes, and how so? Yes.
The ACA, one of the pieces of the ACA is that it is really trying to keep people mindful of the costs of healthcare, as we know. And one of the wonderful things about hospice is that it provides such a dignified way for people to spend their last months of life, but it also makes sense economically. And so as people think about these endless, very expensive rehospitalizations, spending days and weeks in an ICU, and knowing that a person is approaching the end of their life, wouldn't it be better to be at home? Wouldn't it be better to be in the nursing home that they've lived in for the past 2 or 3 years, rather than in this very expensive environment? And so what it leads to is a more holistic approach to the way we're caring for people who are seriously ill and in their final months and days of life.
Now, is there any tension between, the economic incentives for the hospitals, or to keep people in the hospital? That's what they get paid off of. If you're in the ICU, or if you're doing this or that, you need those same people to say, it's time to go to hospice. I mean, is there a tension there? Is it relatively easy to get the doctors to say no?
I think it's really, we've had the good fortune and experience of being part of the lifespan system by providing all of their inpatient palliative care. And so many of the healthcare organizations understand the value and the importance of providing good end-of-life care as well, good palliative care, good hospice care. And so even though you may conceptually think that there may be incentives, I think at the end of the day, all of the healthcare providers, the physicians, the hospitals want to really have a good, strong way to care for people who are seriously ill.
Now, you're a sizable company, you have a lot of paid employees, but you've mentioned you also still rely a lot on volunteers, right? That's still a key part of your work. What sort of people do you have, what do you have the volunteers doing, and do you still need volunteers?
Oh, absolutely. Our volunteers are an amazing group of people, and they do everything from companionship. They do administrative office work at our 1085 site. They take people on errands, patients on errands, etc. One of the really remarkable things our volunteers do is a volunteer vigil, and you may want to say, well, what's a volunteer vigil? When our patients are in their last days and hours of life and they are alone, one of the key core beliefs that we have is that nobody should be alone when they are dying. And so we have a group of volunteers that will call up, and they will sign up in 4-hour shifts to sit with a patient when they're dying. Many of our patients are quite elderly, and with that, many of their friends and family have predeceased them. And so we have this group of volunteers that will go out anytime, day or night, to sit with a patient so that they won't be alone when they're passing away.
Now, do those folks, I mean, is that psychologically difficult or is it the type of person who volunteers for that is perfectly prepared to do it?
Absolutely, the latter, because many of them have had their own hospice experience, and they're not afraid, and they understand the beauty and the value of hospice, and so they want to pay it forward. And there are some volunteers that don't have an interest in that, and that's wonderful, but we have many ways of tapping into the goodwill of our volunteers.
We only have a minute left, but you talk about death obviously differently from how a lot of people do. You think people need to not get over their fear of death, but look at death differently, do you think?
Yes. But I do think people are starting to talk. The conversation has happened. We have the Conversation Project happening throughout the country. And I think as this generation is starting to age, I think the baby boomers will have a different approach. They will want to control things, and they will want to be very frank about how they want to spend their last months and days of life.
And do you see that generationally different approaches depending on the generation that you're helping and assisting?
Yes. For an older population, when whatever the doctor said went, and that's fine, there's a certain amount of respect there, but this is an inquisitive generation that absolutely wants to check everything out online and make sure that they understand this aspect of their life from A to Z, and make sure that they have the ability to control and have a say in what their care is going to be like in the final months of life.
All right, Diana Franchitto, thank you so much for joining me. She's the president and CEO of Home Care and Hospice of New England. I almost messed it up. But they're going to be HopeHealth before a couple months when this transaction goes through. Thank you, Diana, for being with me. And thank you for joining us this week and every week on Executive Suite. Remember, you can catch all the shows on WPRI.com. You can also get them as podcasts on iTunes, and you can listen to them on the radio Sunday nights at 6:30 on WPRO. See you back here next week on Executive Suite. Great.